So my topic is not so complicated. However, as you know, my colleague like Paolo cannot do anything without this part of the diagnostics, because we have to provide the pathological material. And sometimes it's not easy. But first, what is the most important is always to consider the biopsy and to perform the biopsy to establish the diagnosis, because the final treatment plan. So this is a major message which we have generally, not for you as a patient, but generally for the physicians. And still in many situations, this is a major issue which we are facing on, that the biopsy was not done, or the biopsy was wrongly done, or the biopsy was misinterpreted because was not evaluated by multidisciplinary team at the level of the diagnostics. So this is from ESMO Huracan guidelines, and of course the multidisciplinary approach, you know, is mandatory for treatment of soft tissue sarcomas, but it's also a key for the diagnosis. And the best would be if the biopsy could be also performed in the center which will be treating you as a patient, because usually in the centers we have the best team for the pathologists, radiologists, and the people who are doing this biopsy. So generally, as you know, the biopsy should be done for all deeply seated soft tissue masses, so before the muscle fascia, but also for superficial muscle mass larger than 5 centimeters. This is usually the size of the small ball. I know that it was such action organized by some patient organization that if it's larger than golf ball, so we should do the biopsy. So it's nice indication. So for years we performed so-called open biopsy, so surgical biopsy or incisional biopsy, which is usually not done now by us, because it was a surgical procedures with needed at least a local anesthesia, but sometimes also different types of anesthesia, and it was a surgical procedures with complications. But still, in small percentage of situation, we are doing this when we cannot get the good material, and still we have the suspicion of soft tissue sarcoma. So it's still done, or bone sarcoma. But what we prefer now, it's so-called core needle biopsy. So it's thick needle, and we take some punches and we to the mass, and we took some samples. Usually our pathologists want more and more these punches because they have more and more sophisticated tools for the diagnosis of soft tissue sarcomas. It's very small procedures. Small procedure, usually it's done in outpatient, and sometimes with your hands only, sometimes under ultrasound guidance, sometimes under CT guidance, but usually it's very, very simple. And we want to omit such situations. Sorry for this bloody picture, but as you know, I'm surgeon, so I couldn't omit this. This was the patient who had 3 different operations in 3 different regional hospitals, because it is a buttock. It was misinterpreted as a hematoma. Also, of course, it was soft tissue sarcomas, but finally during the 3rd procedures, the biopsy was done. Of course, you see how difficult was treatment of this patient. It was a final treatment after preoperative chemo and radiotherapy. Finally, the patient is okay, but it was much more difficult to plan, for example, the incision, because the biopsy first was not considered, thereafter was also not performed well, because nobody suspected soft tissue sarcoma. And it was about 30-year-old lady. So really, it's difficult to say that hematoma is something typical for such person. What we always discuss, and we cannot understand as a sarcoma specialist, that for breast tumors, core needle biopsy is almost always performed when the tumor is, let's say, 7 millimeters. But it's in many centers which are not experts in sarcomas, and they have general surgeons, it's always the case to discuss the biopsy even if the tumor is 9 centimeters, 10 centimeters. So for me, it's much easier to perform the biopsy of such big tumor than 7 millimeters tumor. But for everybody knows that it's a kind of the standard for breast tumor, but still it's discussed by physician without expertise or without knowledge about sarcomas, and it's often not done. You see here, this is an example of core needle biopsy under CT guidelines. What is the accuracy of the biopsy technique? It's very high. You see that for true cut or core needle biopsy, because true cut is a different name of this biopsy, so it's about 89% of specificity and sensitivity, but not in all locations, because sometimes are difficult locations. However, with this biopsy, not in 100%, but this 89% of cases we can establish diagnosis. Sometimes it's not easy. Paolo told that we need more and more sophisticated techniques to establish the final diagnosis. So you have to get a good material, the reliable material from this biopsy. And you as a patient sometimes are very nervous that it takes some time, and or we have to consider rebiopsy, because sometimes we need more material. However, usually with one true-cut biopsy, we can get the diagnosis of sarcoma. This is how it's done under ultrasound. You see, this is a tumor. This is a tumor. This is the needle inside of the tumor in ultrasound. So it's one of our cases. You see how it's done in the reality. This is very easy because it's a very small hole, and this is you see here the needle, and we take the part of the tumor here. So it's very, very easy. It's really under local anesthesia in the outpatient, and this is the core, and we take some cores which should be at good quality to get the final diagnosis, and the final diagnosis was established. Sometimes the location is difficult. This is from neurosurgical or orthopedic paper for lesions located near the vertebral column. You see that clinically effective biopsy was here for the malignancy 94%. So it's a little bit lower. However, it's the most common procedure, even with difficult locations, because here you may see, core needle biopsy. This is an incisional biopsy. It's an excisional biopsy. It's a very low minority performed. But you see that the complexity of the biopsy under the different imaging is now very high. But we can take the material almost from every part of the body. Sometimes, as I said, still we need the open biopsy, but it's very rare situation. So what is the best sequence when we have the suspicion of the soft tissue sarcoma or bone sarcoma? Of course, imaging. then perform the biopsy, and then the grading, staging, the final diagnosis. So why we need the imaging before the biopsy? This is from magnetic resonance imaging, so MRI, because you see that soft tissue sarcomas inside of the tumors are heterogeneous, are not uniform. So these tumors have internal heterogeneity. So you see that we want to take the biopsy not from the part of the tumor which is most suspected about the high-grade part, so it's more malignant part, to have the final diagnosis made on the biopsy and without the necrosis, because necrosis, necrotic part of the tumor has a low percentage of the cells there. So you know this is famous, famous oculobrachial reflex, showing sometimes the pathway which is ongoing on surgeons. When the surgeon is seeing the tumor, taking the knife and cut out of the tumor without the diagnosis. This is very bad situation because, as you know, it omits the brain. And when it omits the brain, so usually it's done wrongly. So this is why we need the normal pathway. So when we see the tumor, we have to discuss it. We have to think what it can be. We have to do the imaging, do the biopsy, and thereafter establish the treatment for you. So this is the worst situation, you know, from the when it's lack of multidisciplinary team, because the biopsy was not done. So I do not know what is it, but I will operate you immediately because it's a tumor. So I don't know why you need to be in a hurry. You should do it after thinking, after recognition, what is it? But thereafter, you have the diagnosis of the sarcoma. The sarcoma was wrongly operated, and now you have to go to the oncologist. Of course, this is not a right sequence. You should think before and do the biopsy and establish the diagnosis. What is the impact of unplanned excision? First, unplanned excision, especially in high grades of tissue sarcoma, results in increased rates of local recurrences. This is first point. There are also some papers that it decreases the overall survival when the biopsy was not done because the treatment was wrong. However, of course, it's not so easy how to evaluate this, but we know that if the biopsy was not done, usually the unplanned surgery is done wrongly, so it means that you need more complicated treatment and reoperation in many cases. So generally, it's especially bad for you as a patient. So MDT is done when you have the diagnosis, but also to establish the diagnosis. So, and experienced pathologists must evaluate what we're taking as a biopsy. Usually the biopsy is done currently under the guidance of imaging, ultrasound, MRI, CT, etc. So you see that the algorithm of the treatment of soft tissue sarcomas, but also bone sarcomas, it's always based on the diagnosis first, and thereafter you have the different paths how to treat the patients, but without this first expert decision, you cannot do it. This is the real pathway how we treat soft tissue sarcoma in our department. This is, of course, because we are discussing every different situation, and we try to individualize the pattern of the treatment of every patient. So this is why we need this part. So well defined what the tumor is. And you see that every 7-8 years, we have some new entities within the soft tissue sarcomas. This is, of course, the fault of Paolo, what can I say? But for us, it's the most important because we can individualize the treatment. What about other locations of the sarcomas, not only extremities or the trunk wall, like retroperitoneal sarcomas? Of course, the issue is that sometimes after imaging, we do not know where is the soft tissue sarcomas of the retroperitoneal space. So when we look at this imaging, it's probably difficult to guess where is sarcoma. Maybe Paolo knows. But generally, when we get the CT, especially from not experienced centers, okay, is retroperitoneal soft tissue mass, it can be sarcoma. But of course, only in one case is real retroperitoneal sarcoma, because it is germ cell tumor, it's a chondrosarcoma of the rib. This is the differentiated liposarcoma, it is a schwannoma, so it's benign tumor. This is lymphoma, which usually do not require surgery, but systemic treatment. This is neuroendocrine tumor. So this is why we need this diagnosis to have a good treatment for you. What are the complications of the biopsy in retroperitoneal tumors? It's very low. For malignant tumors, you see this is 2%. And what is accuracy of this biopsy is very high, especially in high-grade tumors, because for the problem is how to sometimes differentiate between the differentiated, so higher grade liposarcoma and well-differentiated liposarcoma. This sometimes can be issue because the part, well-differentiated part of liposarcoma can be dominant, and sometimes it's difficult to put the needle, the puncture into the small part of the high-grade tumor. So this is a discrepancy. We can establish the diagnosis of liposarcoma, but sometimes we are not sure based on the biopsy that it's the differentiated liposarcoma. Also, based on the imaging, we know leiomyosarcoma, it's, as you see, much easier in this case. What about GIST? Sometimes we do not need a real biopsy, because if we have small submucosal tumor of the stomach, for example, so it's difficult to perform the biopsy, and when we are considered the surgery, so the surgery is done with small margin, usually it's enough. But the biopsy usually is much more complicated, because it's biopsy done through endoscopic procedure under endoscopic ultrasound guidelines. So we put the endoscope into your gastrointestinal tract, and from the inside we try to do the biopsy, which is sometimes tricky. You see here, this is the needle here in this submucosal tumor. This is the inside of the stomach, but we can establish as well the final diagnosis in many cases. This is important because when you have larger tumors, and sometimes we are discussing what the approach would be the best. So you see here, this is 4-centimeter tumors, and this is GIST CD117 positive, so go to the operation. But it was leiomyoma in 80-year-old patient. So this patient does not need operation because it's benign tumor and usually not growing.
Piotr, you just reached 20 minutes, so
okay,
look at the time, please.
Or four slides, and everything will be finished. So you see also that still with this sophisticated biopsy, we can get the Good specimen, only about 2/3 of the cases. In inoperable tumors, it's always the standard of care to perform the biopsy. So the biopsy is always necessary to confirm the diagnosis of primary GIST prior to initiation of preoperative therapy. Percutaneous image biopsy may be appropriate to a confirmation of metastatic disease. So diagnosis of GIST, biopsy before planned operation, MDT, and therapy. And the same, you see that sometimes the diagnosis is difficult because only here is GIST, but all other imagings are very similar. The biopsy, MDT, plan of combined therapy. And thank you very much for your attention. Some slides from Warsaw, maybe not only from the spring, but generally, I really would like to meet personally. And thank you for, also my team from Department of Soft Tissue Bone Sarcoma and Melanoma from National Research Institute of Oncology, which is completely multidisciplinary team. Thank you very much for your attention.